All right. All right. Now we're recording. Well, hello, everybody. I am humbled and excited to share with you today. So thank you for taking your lunch break uh, to spend it with us. Um, so today we're going to talk a little bit about is it OCD? And one of the motivations for doing this psychoeducation session is because a lot of times when I get clients who come in for OCD, one of the first things they are trying to ask is like, do I actually have it? And the second part is uh, just repeatedly hearing these stories of, I know I have OCD. I've went to go get treated for it before, and I did a type of therapy that just was not helpful. It felt like it made it worse. So hopefully today we can have a little bit more information so you can figure out if you need to get additional assessment for OCD. And also we'll talk about some treatments that are relative and evidence-based specifically for OCD. So I wanted to take a moment and talk a little bit about what we are going to focus on today. Mostly, we're going to understand OCD in accordance with the DSM, the Diagnostic Statistic Manual. And that is kind of the clinical go to for deciding if a person has a mental health disorder or not. Number two, we're going to look at some different forms of OCD. There's a lot of different subtypes. So there might be some specific things that come to mind whenever you think of OCD, like contamination or like ordering things a specific way, which can be part of OCD, but there's a lot of other flavors out there. And third, we're going to identify some resources to treat OCD. So we want to make sure that you are well equipped if you do feel like you need to take that journey to have the information at your fingertips. I also want to mention what this presentation will not do. So I'm not going to be able to help you self-diagnose OCD. So only a licensed clinician who is assessing you can do that. So even if at the end you have some questions, I will answer them as best as I can, but I will not diagnose you. So um, also, uh, this is not going to give some skills to manage OCD. So I might talk about some different types of treatments, but this is not going to be a skill focused session. And last but not least, this is not a CEU. So sorry for those of you who are clinicians, although if you have some questions about some solid sources for CEUs for OCD, I'm happy to chit chat with you afterwards. Samantha's a great resource for that as well. I also do want to point out that a lot of this information is geared towards adult OCD, not necessarily OCD for children. However, with the resources that I'll be sharing with you, some of those can be good starting points to find out uh, additional resources that are children specific. So let's look at OCD in accordance with the DSM-5. So what is OCD, or obsessive compulsive disorder? OCD is the presence of obsessions, compulsions, or both. And we'll talk a little bit more in detail about that. The obsessions or compulsions, this is the part that makes it officially a disorder, is that it is time consuming. It takes more than an hour a day, or it causes clinically significant distress or impairment. So we're looking at like, is this disrupting a person's ability to function at school? Is this disrupting their ability to work? Is this getting in the way of their relationships? Are they able to just not physically leave the house because of their OCD symptoms? So if either of those criteria are met, then we could call this a disorder. The obsessive compulsive symptoms are not attributed to other physiological means or substances or a medical condition. So if a person uses a substance and then suddenly they have obsessions or suddenly they start doing compulsions, that's not going to be under the OCD category. There might be some other diagnoses for that, but for what we are talking about today, we're not going to consider that OCD. And then the disturbance is not better explained by the symptoms of another mental health disorder. So there are some mental health disorders that are under the umbrella, they're OCD-like, like maybe body dysmorphic disorder or illness anxiety disorder. Uh, Another one that comes to mind, phobias can look really similar. So if there is a more specific disorder that describes it, we're not going to call that OCD. We're going to call it whatever that more specific disorder is. But some of the treatments for OCD can be similar and very helpful for those. So let's dig a little bit deeper into obsessions. How are obsessions defined? So they're going to be recurrent, they happen over and over, persistent, can't get rid of them. And they can be thoughts, urges, or images that are experienced as intrusive, unwanted, really want you to remember that, and cause marked anxiety or distress. So these thoughts are going to be, they may seem bizarre whenever we have these thoughts. It could be something like, what if I just push that person in the traffic? Or it could be an urge to go back and check the door just one more time. Or it could be an image of a loved one dying. And so these are going to be disturbing. So they're just going to pop into the mind. They're not necessarily prompted, and they're going to be unwanted. We call that ego dystonic. It's the opposite of what the person wants. And that's why it causes that anxiety or distress. Distress can be anxiety, but distress can also be guilt, shame, horror, just any kind of unpleasant emotion that the person's going to want to get away from or dissociate themselves with. Secondly, the individual is going to attempt to ignore, suppress, or neutralize these thoughts, urges, or images with some other thought or action. So that's the compulsion, is whatever we're doing mentally or physically to separate or push down the stress from that intrusive thought. Now, I want to pause here and mention everybody has intrusive thoughts. So if I mention a thought that you're like, ooh, I've had that thought before, everybody gets intrusive thoughts. The difference between it becoming an obsession versus just a one-time intrusive thought is that with OCD, that intrusive thoughts can be really sticky. Can be really sticky. It's not going to be one that they can get away with. Where if a person who has OCD is going to keep thinking that thought, a person who doesn't have OCD is going to be like, that was a weird thought. And they're going to move on with their day. Person with OCD is going to have that thought or urge or image, and they got to do something about it. So when we look at the other side of compulsions, compulsions are defined by just that drive to do something in response to that obsession or rigid rules. So this person can have it could almost be an if then, like if I don't hug my loved one 3 times before they leave, then I'm afraid they might get into a wreck. So I have to do it. I have to do it just in case. It could also be repetitive behaviors, like maybe a person is walking in and out of a door until it feels right. And they're like not sure how many times they're going to walk through that door, but they're just doing it until it just feels okay. Or it could be some mental acts like praying, counting, repeating words silently. Mental acts are basically going to be, or mental compulsions, they're going to be the compulsions that we can't see. So they will be in response to that obsession or that distress. They will be designed to bring the distress down, but a lot of times people can't see them doing it. And so the mental compulsions can sometimes take longer for people to come to treatment for because they can hide them easier. Whereas if you're washing your hands an excessive amount of times a day, you're not going to be able to hide that so well. Another element of it is it's aimed to prevent that anxiety or distress or a dreaded event or situation. OCD, those obsessions are going to kind of go to worst case scenario, and those compulsions are designed to prevent that catastrophic event. But the tricky part with compulsions is that compulsion doesn't necessarily have to be related to the catastrophic event in a realistic way. So, or it could be excessive. So we might look at somebody might have the compulsion to knock on wood. This is something that you do every now and again. I wouldn't consider it a compulsion. If it's something that you absolutely have to do, like I cannot move on until I knock on wood after that thing that I just said. Uh, we know that knocking on wood 9 times out of 10 has nothing to do with whatever feared outcome we're thinking of. However, it's just kind of part of the compulsion and the obsession. It can also be something that is clearly excessive. Or, I'm sorry, let me take a step back. When these compulsions are not connected in a realistic way to those obsessions, sometimes it can bring up a lot of like feelings of shame, guilt, frustration for individuals who have OCD because they're like, this is not rational. And OCD isn't rational. That's how we can know that it's OCD and not anxiety, is because while anxiety is a fear of, something that is truly possible happening, a lot of times OCD is fearing something that is really not likely, maybe even not even possible connected from happening. So as far as like the guilt and shame and maybe even dread that comes from that, what I usually tell my clients is like, look, if somebody had the flu, you wouldn't get upset with them for sneezing. So this is just one of the symptoms of OCD. With the clearly excessive, there can be some things that we just naturally have to do. We got to hand wash, or well, I hope most of us hand wash, right? So it's not that we're doing the hand washing, it's that we are doing it to the point of excess. If you're spending a couple of hours a day washing, showering, cleaning, grooming, then that's going to be the compulsive act. If your hands are becoming cracked and they're bleeding, now it's excessive. Now that's a compulsion. So, how does it work? I kind of already alluded to this before, but this is the OCD cycle that I like to show my clients. The obsessions, unwarranted thoughts, images, urges. Sometimes I even like to put in their sensations because there can be some sensory OCD that can kind of come in there. Causes the distress, any kind of unwanted emotion. Doesn't have to be anxiety, although that's the one that is probably most easily named, which leads to a compulsion. Compulsion is going to be a mental or physical act to get away or decrease the distress of the situation. One part that can be kind of hard to catch with compulsions is that avoidance can be a compulsion too. And we do this, why? Because it does bring some relief. It's just that the relief is only temporary until the next obsession occurs. So an example of this might be person has an image or thought pop into their head while they're driving of hitting a biker. And so they experience distress. They're horrified. They feel guilt. They feel shame, fear. They might even have like this secondary interpretation of what does that say about me that I would hit a biker? They go into their compulsion. They can pick any number of compulsions. They might just avoid driving because they don't want to deal with the distress. They might drive, but be constantly checking their rearview mirror to make sure that they didn't hit anybody. Maybe they're driving super slow. People are honking at them. They're going to be late to work. They don't care. They want to make sure that even if they do hit somebody, it won't be fast enough that that person would get injured. They might circle back around the block, retrace their steps. They might even do some researching or reassurance seeking by checking the news nightly for hit and run drivers. And they cannot go to bed until they check everything in their area or in the area where they drove. Okay, no reports of hit and run drivers. That means I'm safe for tonight. And they'll have some relief, but it's only until the next trip. Only until the next time they have to get in that car only until the next time they pass by a biker where they might have that image of him. So that's kind of how the cycle plays out. And sometimes, even with some of those avoidance behaviors, it can get to the point where it's like this ritual or this compulsion is so exhausting. I don't want to even be in a situation where that image can come up. So I'm just not going to drive anymore. I'm gonna take the bus. So that's kind of when we can notice these things really affecting our daily lives. So how does one get OCD? Well, it's not really gotten, really. It's just, it can have an onset. And this can be anywhere between preschool and adulthood. So there are children who have OCD, and it can be recognized. I was listening to one story about a gentleman who had OCD, and he noticed symptoms when he was like 3 years old. I think it's kind of hard to catch symptoms at that age, but um, sometimes life stressors can contribute to the onset, but it's not necessarily the cause. So, like, stress gets so high, and the person may notice. I have a lot of clients that did not become aware that they had OCD until they were maybe in college or something, and they had a lot of high pressure around them. It can have a genetic component, but not always, but it's not uncommon when I talk to folks and we kind of go through the symptoms that they notice, oh, yeah, I didn't think it was OCD before, but my mom actually does that all the time. I think she might have it. So it can run in the family. Usually the person's not the only one who has it. With pandas and pans, this is more a childhood disorder where the sudden onset of OCD symptoms happens after like a childhood infection. So usually that infection might be like strep or something, but it is quick and it's noticeable, a distinct change. We're not going to get into that for this presentation, but just kind of knowing that it's out there and some of the resources that we'll talk about will also have a little bit more information on that. And the biggest thing I want to remind you is that nothing traumatic has to happen in order to trigger OCD. So it's not like, oh, you had this monumental thing and that's why you had OCD. Like, no, OCD and PTSD or trauma can be concurrent or co-occurring, but trauma is not going to be the cause of OCD. So it's kind of independent. We're not really sure why some people have it and why some don't. But trauma is not a necessary precursor to it. So you may be wondering, seriously, how do I know if it's an intrusive thought? Well, like I said, everybody gets intrusive thoughts. We've all had some weird thoughts before, but it might be a stickier OCD thought if there's some urgency to that thought. Like it feels like something you gotta react to right now. We cannot wait to respond to it. If there's some intolerance of uncertainty around the thought, OCD has often been called a disorder of doubt. And OCD does not like doubt. It does not like uncertainty. So if there's an intolerance of uncertainty around that thought, I have to get to the bottom of this. I got to research it until I find out. I have to get some answers. That may be an indicator. If you suspect your actions or precautions are excessive, if you are going above and beyond what a reasonable person might do. And I know that can be very hard for us to ascertain, but usually if you got somebody in your life who cares about you, they will usually let you know if the behavior is excessive or like, okay, this is a little beyond what most of us are doing. If the intrusive thought is connected to like some kind of catastrophic event or threat that's not imminent. So oftentimes like the core fear when we get down to the bottom of it is like, I'm going to die. I'm going to die, or I'm going to go to jail, or I'm going to harm somebody beyond repair. Usually that's the catastrophic threat that's trying to be avoided. But more often than not, we, and this is kind of where we talked about that rationality part. It's like, I know nobody's going to die, but still, I still have this persistent thought that somebody's going to die. If the action that we're taking doesn't correlate with the feared outcome, or if it just feels like a command that you gotta obey just in case, then this could be a sign that it might be an intrusive. So what's the difference between compulsive acts and impulsive acts? One of the reasons why I added this in here is because I have a lot of clients who have both OCD and ADHD, and it can feel really confusing. Like, is this a compulsion? Is this impulsivity? I don't know. So first, let's clarify some different examples of compulsions. There can be things like visually checking. You got to look at it. You got to look at it again. You got to look at it. Now I'm keeping my eye on it to check to make sure that that thing is as I want or desire or need it to be. We can do tapping, repeated touching of items, whether that's a check or if that's kind of a just right response. We can return to check items after leaving. And this could be opening up the door to your home right after you just locked it. This could be driving from down the street to come back and check whether or not you locked it or turned off the thing. Reassurance seeking from other people. Like, you saw me turn the lights off, right? And they say yes. Are you sure I turned the lights off? Okay, but like, are you sure that I turned the lights off? Like, do you think something really bad is going to happen if we don't go back? So reassurance seeking, we're usually trying to get some kind of comfort from somebody who's not going to know the information any better than we do, or we're just not accepting the first answer. Repetitive and ritualized behavior. That might be doing things in a certain order, a certain way. Avoidance. We talked a little bit about that earlier. Maybe we're trying to avoid a threat that hasn't even presented itself or shown itself to be there. Mental review, that's going back over all the things, like with a fine-tooth comb. Okay, I said this, and then they said this, and then I did this, and we're just kind of replaying that tape over and over again. On the other side of it, mental rehearsals, we're planning out everything that we're going to do. Emotional checking. So that might be like, oh, when I hugged her, did I actually feel love? Like, did I feel enough love? Am I feeling love now? Body checking, where we're trying to check our body sensations, whether that's looking for an abnormality in the body or checking our body for response. Scenario bending, that's going to be, if you've seen Butterfly Effect, like half of my clients remember that movie, half don't. Or if you've watched any kind of time travel movie where the person changes one tiny thing in the past and then everything in the future is completely different. Imagine doing that in your mind over and over and over for every decision and almost every situation. Compulsive flooding. And so that might be like maybe purposely exposing yourself to something that's aversive and checking to see, like, do I have a disgust response? And if I don't have a disgust response, what does that say about me? Does that mean I'm a terrible person? So all of these can be, this is not an exhaustive list, like I said, but all of these can be forms of compulsions. Oh, and confessing. So, we might start confessing to things like they don't know. I mean, they say that I'm not a bad person, but they don't know everything I've done. So I'm going to go ahead and start confessing, or maybe with religiosity, confessing like small mistakes as a way of like trying to like purge or get some comfort or reassurance that you're not a bad person. So when we look at compulsivity versus impulsivity, here's how we know. And I always talk to clients, look at the function. What is the function of it? Compulsivity is ego dystonic. It's not what we want to do. Impulsivity is ego syntonic. It's what we want to do. Compulsivity is going to be threat or stress avoidant. We're trying to get away from something. We're trying to decrease the stress. Whereas impulsivity, thrill seeking, stimuli seeking. We're looking for the shiny thing or the thing that makes us feel good. Compulsivity is going to be rigid and rule following. Even though it might feel almost reflexive at a certain point, that response is based in a personal rule. I gotta do this thing or X will happen or X won't happen. Impulsivity is disinhibition. Impulsivity doesn't care about rules, not thinking about rules. It's just kind of like letting it ride. Compulsivity is trying to avert risk. Impulsivity has some risky behavior to it. So, and also kind of pointing out here, impulsivity can be a symptom of multiple mental health diagnoses. That can be ADHD. It can be substance use. It can be part of a manic state or episode as part of bipolar disorder. Impulsivity can show up in all kinds of mental health diagnoses. Compulsivity is going to be fear-based. Impulsivity is emotional, pleasure-based, arousal, gratification, that stimulating thing. Compulsivity exaggerates the likelihood of harm, whereas impulsivity underestimates harm. I like to call impulsivity uncautiously optimistic. It's not thinking about what can go wrong. Speaking of which, compulsivity assumes some negative outcomes, or it's trying to avoid those potential negative outcomes, where impulsivity is not even thinking. There is no foresight about negative outcomes. That's usually happening afterwards as a part of the consequence phase. So if a person's in doubt, I'm always going to say, what was the intention? Was it to feel good? Was it what you wanted? Or did it kind of go against everything that you desired? And then we can kind of sort it out. So let's look at a few variations on OCD. And this is honestly one of my favorite parts, but I'll try to keep it brief for time's sake. But there's some different subtypes to OCD. This is not an exhaustive list of subtypes. Depending on which source you go to, they're going to give subtypes different ways. But these are some common ones, or I just kind of like the way that this particular source had separated out. So responsibility and checking OCD, that can kind of go with the, did I lock my door? Did I turn off that appliance? And that checking compulsion, going back to check. Usually the fear with that responsibility and checking OCD is, did I do something that would cause harm, or did I fail to do something that I was supposed to do? And there's a negative consequence for that. With another one that I can see in responsibility and checking OCD, like, oh, did I send that email? And here's kind of like the intrusive thought that's not necessarily rational, but we have to go back and do the checking behavior. When I sent that email, did I put an expletive in there, or did I send an attachment that was inappropriate to the job? I know I probably didn't, but I got to go back and check, just reread that email, make sure that I didn't have any expletives. I'm not going to feel at ease until I do. So it can show up in that kind of way. Harm OCD, I think harm OCD can have a pretty big umbrella. This can be fear of kind of snapping and doing something harmful to somebody else. This could be a fear of doing something harmful while in an unconscious or dissociated state. This could be fear of harm happening to somebody that you love. This could be a fear of doing something accidentally and not realizing it until the police come for you. So harm OCD and responsibility and checking OCD can have some overlaps to them. Any of these can. But that's what that one can kind of look like. And so with harm OCD, this might be a person who's like, I'm not gonna hold that newborn baby because I just got an image of myself dropping the baby, and that's the last thing that I want to happen. So I think it's just better if I stay away. Avoidance can be pretty big in there, and a lot of there can be some mental compulsions happening as well too with all of these. Sexual orientation, OCD, this can go in as many directions as there are sexual orientations. So like let's say a person who identifies as a lesbian might have sexual orientation OCD that like, what if I'm actually straight and I didn't know it? What if I've been lying to everybody all this time and I don't actually know who I am? And I haven't been representing myself appropriately. This person could be married and have a family. And it doesn't matter what the sexual orientation is. It's questioning the sexual orientation that one is presenting to other people. Once again, this is ego dystonic. So it's like it's not a curious questioning, like I'm exploring this about myself. It is a fear-based questioning of what if I got this wrong? And so this is one where emotional checking, body checking, maybe even avoiding um, people that the person might worry about being attracted to, or maybe purposely doing some compulsive flooding to see if, am I attracted to? Does this raise some feelings for me? And I'm going to skip down to pedophilia OCD because it can have some similar qualities of that questioning of what if I'm attracted to someone that is incongruent with what I want for myself. Only this is more children focused. So I don't want that one to freak you out because it's ego dystonic. And this is how we know that it's OCD. If a person has pedophilia OCD, they are going to feel horrified at the thought or possibility that they could possibly be attracted to a child. They will still do some of those body checking behaviors, maybe some compulsive flooding, but they're going to do actually the opposite of what an actual pedophile would do. They're going to avoid children. They won't even walk by a playground, or they might refuse to babysit a child, or like, I'm not going to be alone with a child. Another adult has to be present. So, but things that are excessive to what would be normally expected. So it's ego dystonic. It is the opposite of what the person actually values. Relationship OCD. This is another one that's a little trickier because relationships are rife with uncertainty, and relationship OCD is going to look for that certainty. A lot of the fears might be very what if based. What if they're not right for me? What if I'm with this person and I'm missing out on the person I'm supposed to be with? What if they're with me and they're missing out on the person that they're supposed to be with? And so we might see some emotional checking with this one, some body checking. Am I attracted to my partner? Do I love my partner? Like, did I feel love last time I said goodbye or when they went on that trip? Did I feel enough of it, or was there a lack of it? What does this mean? Right. And so a lot of reassurance seeking can come up in this one as a compulsion. Contamination OCD. I'm not going to spend a lot of time here because this is probably the one that folks are most aware of, but long story, just kind of a fear of certain, I think textures can come under here too, but a fear of exposure to something that will contaminate the person. Sometimes it can be like, I don't want to get sick and die. I don't want to make somebody else sick and die. And so you can see how that can tie into some of that harm or responsibility and checking. And so the compulsions will be very intense around cleanliness. We might even have the person doing some family accommodation behaviors, which means other people are like, you know what, before you come in, you have to do a ritual before you can come into my uncontaminated space. That way you don't bring the outside contamination inside to my uncontaminated space. Hyper awareness and sensory OCD. The best example I've seen of this is like, have you ever noticed the side of your nose? Like if you look down your nose, have you ever noticed the side of your nose? With hyper awareness OCD, maybe the person's like, okay, now I can't stop seeing the side of my nose now that I look down the side of my nose, and it's distracting and it's driving me nuts. Or becoming aware of our not our natural bodily responses, like breathing or our heartbeat. And it's like, oh, now that I'm aware of my breathing, I feel like I have to control my breathing. And I'm afraid that if I don't control my breathing, that I'm going to stop breathing. And I know that's not rational, but I can't stop thinking about the breathing. So, you know, it can be any bodily response, it can be any sensory response, and a compulsion to constantly check with that. Just right OCD, that's kind of one of those where we're a little bit more familiar with. It can be aesthetic, things have to be in its place or in a certain order. It can also be mental compulsions, right? I have to finish my sentence on an even number of syllables. If not, I got to start the sentence over again, or until it feels right. So, just right OCD is a lot about like until it feels right, until I get it right. We can see a lot of perfectionism in here, as well as with religious OCD, or moral scrupulosity OCD. Um, with the religious OCD, the core fear is like, I'm not doing my religion or belief right. And so maybe it's going above and beyond. I got to say the prayer until I mean it. I got to say the prayer the right way. I have to restart the ritual, or that means that my higher power or will not accept what I'm doing, my religious behavior. Once again, ego dystonic, this person actually really cares about their religion or beliefs, but it actually leaves them more disconnected from those beliefs because they're so busy doing the compulsion. They're not doing it from the space of uh, whatever made them believe their value system in the first place. And moral scrupulosity, very similar, high scrutiny of what a person is doing and whether or right it's moral or ethically right or wrong. Um, and this can bring a lot of guilt and shame if the person doesn't feel like they performed or did something to that morally scrupulous standard. So, all of this to say, the content of the OCD is irrelevant. The content is irrelevant. OCD is going to attach itself to whatever is important in that person's life at that time, or often does. So it's not uncommon for somebody to say that they had hyper awareness earlier in their lifespan and they just had a kid and now they have harm OCD because they're worried about harm coming to their kid. Or, they're doing a very analytical job. So now they have a lot of just right and moral scrupulosity OCD. Doesn't matter. What matters is the treatment or the exposures will be tailored to whatever the person is dealing with or causing distress at that time. So we're in the final stretch, y'all. I think it may be OCD. Where can I find help? So some evidence-based treatments for OCD is going to be exposure and response prevention. This is traditionally known as the gold standard treatment for OCD. I'll talk a little bit more about what that looks like. Um, Medication management, SSRIs, with exposure and response prevention and medication management together, about 7 out of 10 people notice improvement in their OCD symptoms or decrease in their OCD symptoms. Acceptance and commitment has been another up and coming therapy. It's also under that cognitive behavioral therapy umbrella, but it has, I kind of see it as a very holistic complement to ERP, and it can be used concurrently with ERP. Inference-based cognitive behavioral therapy is another emerging type of therapy. You wouldn't do exposure response prevention and inference-based cognitive behavioral therapy together, but I'll show you in a moment a graphic of what the inference-based cognitive behavioral therapy focuses on. So exposure and response prevention. I just want to clarify, like you might have seen some extreme versions on TV, and that is great for TV. but exposure response prevention is really a courageous act of willingness on the part of the client. So this is just a process of exposure to stimuli that provokes that fear response for the person. And the person agrees to it. So typically when we do exposures, we'll work it with the client. Like, okay, what needs to go on this list of exposures? So we're not doing anything crazy or harmful with the client. We're going to kind of check in with the client, like what's meaningful to your life? What have we been avoiding that you actually want to do? And then maybe that will go on the exposure. So it's collaborative and the client is willing to do it. The therapy doesn't work if the client is white knuckling it and unwilling to do it. So this is gradual exposure over time. We learn to decrease our sensitivity to that stimulus by changing the external response and allowing those feelings and compulsive urges to be there without necessarily letting them dictate those actions. It can be effective for obsessive compulsive disorder, phobias, and body dysmorphic disorder. And exposure, I kind of already explained this. The response prevention part in a nutshell is just not doing the compulsion. I recently had a client, and I asked their permission if I could share this. They're like, so exposure and response prevention therapy is basically like microdosing anxiety. And then we like probably laughed for a full minute after that. I'm like, that's a pretty accurate description. May I use that? So that's shorthand if you want to know what you might be getting into. Selective serotonin reuptake inhibitors. These are medications that are often used as antidepressants, but they're going to be used at a higher dosage for OCD. So here's a list of some that are often prescribed in order to treat OCD. And if you want to see the actual dosage levels, you could probably, the International OCD Foundation will be a great resource for showing you like what some typical dosage levels look like for that. Acceptance and commitment therapy. Basically, it's trying to get folks to live a meaningful, purposeful, value-based life. This incorporates acceptance and mindfulness, two things that you're already going to practice in exposure and response prevention. Living in the moment, experiencing things without judgments. We're going to allow those emotions to come. We're not going to judge them, but we will tolerate them and willingly allow them to be there. Commitment and behavior change as a way to cope with unwanted thoughts. So this might be a person doing something that they want to do instead of what OCD wants them to do. Then there can be some values and like detaching from those unhelpful thoughts and words in there, and just making some observations about the experience instead of allowing the experience to dictate the person's state of mind. Inference-based cognitive behavioral therapy. Basically, it looks at obsessions over doubts and the stories that we write about those doubts kind of take over. And now we're relying on our imagination of what's going to happen instead of what are my senses in this moment telling me is actually happening. So the treatment challenges kind of those narratives, those imaginal narratives, and it kind of moves us more towards the center of normal doubts. And like, okay, we can respond to those normal doubts, but we don't have to respond to the obsession doubts. And so this is kind of like a brief model of what these interventions can look like. And so inference-based CBT is going to be a little bit more cognitive-based. And this one has, they've been studying this one for 30 years, and they're seeing some great results with inference-based CBT. But you don't actually do exposures with this type of treatment because they hit the doubts. They target the doubts. They're not trying to change the belief here in the center where CBT typically targets. it targets the doubts, whereas ERP is going to be a little bit on the behavioral side, and it's going to target the anxiety, or it's going to allow the anxiety and trigger the anxiety, and then it's going to target the behavior of not doing the compulsion. So these resources, International OCD Foundation and the Anxiety Depression Association of America, they both have lots of psychoeducation, provider directory, and resources for both individuals who have OCD and providers. And they also offer some support groups. And then here's some different apps below: No CD, Act Coach, We Croak, where they like send you some daily reminders to think about death, which can be an exposure, an anxiety challenger. And so these are kind of guides that can assist during the therapeutic journey with OCD. No CD actually has providers on through the app, and they have free support groups that are led by clinicians. So, here are some helpful books. By no means is this an exhaustive list, but once again, if you go to IOCDF or ADAA, you can find an even more comprehensive list of helpful books. But these are some that I like to use or work with my clients. And that is it. Here's some references. And I'll take a moment